Hello, so we're here today to talk about this publication, The Bridge, that Jonathan and I worked on together, the format of which was devised by Leslie Fang. I'm sure many of you enjoyed the webinars that he did for us over here on COVID. He's from Harvard in the States. But we thought we would just pick one of the topics today to talk about. And Jonathan is an orthopedic surgeon, and of course, over the course of certainly my career, the guidance has come and gone a little bit about whether we need to think about antibiotic prophylaxis and joint replacements. And I think you said that's one of the most common questions that you are asked by dentists, Jonathan.
Yes, in fact, it's just about the only question I get asked by dentists. And it's not uncommon to get an email from a dentist saying, oh, I've got one of your patients and they're unsure, we're unsure, could you give us some guidance on whether we should be giving your patient antibiotics because of the fact they've either got a hip or, in my case, mainly a knee replacement in place. And it's an area that I think over the years has been a little bit controversial. And the advice is still pretty clear. And as we say in the book, prosthetic joint infection following dental work is extremely rare. And indeed it is. But we do see infections arise from infections elsewhere, and it might be that some of those are from the mouth. But I think that overall, if you were going to be an economist, you'd say don't give antibiotics. But if you're the individual who's having the dental work, they're going to be asking, what are you doing to protect my joint? But overall, I think the advice is you don't give antibiotics. But they've slightly softened their view, and that I think there is a little bit of wriggle room for you to make a common sense judgment. So, as we say in the book, if there are good reasons and a good case to be made why a patient might be slightly more vulnerable to the effects of infection, and if their joint replacement is a little bit more vulnerable, there is a little bit of wriggle room to allow prescription of antibiotics. But as a routine, probably not.
So in the book, we follow Leslie's format and just give a clear guidance as to the sort of decisions that you should be making. But of course, it's talking about staphylococcal species as being the issue, which, as we know, are really prevalent in the mouth. And one of the guidances here talks about if it's deemed necessary by the orthopedic surgeon. What are the sort of circumstances that would deem you, to advise that maybe it was necessary?
I think if a patient has not long had their joint replacement, I think there's going to be still quite a lot of inflammatory change around the replacement. And for me, I would feel a little bit uncomfortable saying don't use antibiotics. So let's, for example, say if the patient's had a joint replacement in the previous 6 months and they were having some dental work, and especially if there was some infection present in the mouth that you were treating, then I would feel for the sake of one dose of antibiotics, you probably should use it. Now, of course, that's not going to apply to everyone, and someone who's had a joint replacement working for 5 years is not going to get antibiotics, and I wouldn't normally do that, again, unless there was obvious infection present that you were treating. But then I guess although surgery is your primary control of the infection, you're likely to be prescribing antibiotics anyway.
Yes, yeah. It's just interesting to know from the other side what the considerations would be, because we used to always prescribe antibiotics, and then that was changed. So it's very interesting to see that there is a middle ground.
Yeah, and we get and as you held up the page there, Elaine, as well, and as we have sort of the color coding for areas to take particular note of, and as we say in here, if your patient is immunocompromised in any way, then of course their ability to deal with that infection, either they're more likely to catch something, but also less able to deal with it. So patients with conditions that are causing immunosuppression. And the obvious ones and common ones would be things like diabetes, particularly with poor glycemic control, as we say here. And then there are diseases like rheumatoid arthritis that are immune diseases themselves. So I think you just need, and those are going to be picked up in your history. And I don't think it's unreasonable to prescribe antibiotics for those individuals. What antibiotics do you tend to use to cover staphylococcal infections?
Generally, our first line is amoxicillin. That's,
Mm-hmm.
for most dentists, that's where we start, unless there's a medical history reason not to prescribe that. But we're generally pretty comfortable with that, unless there's an allergy, obviously, to penicillin. And of course, that's again where I find the book very helpful, because we tend to know what to prescribe when everything is straightforward. But when things start to deviate, that's where, just using the flow charts is helpful to just double check your thinking.
Yeah, it's always quite useful. I mean, it's not uncommon for me to want to speak to a microbiologist to take microbiological advice in certain situations. But as you said, what we've done is we've given some options here. So your standard go-to might be amoxicillin, but cefalexin, perhaps if you were thinking more of a staph type of infection. And then, of course, you do get actually a very high proportion of the population say they're allergic to penicillin, and it may be that they've had at best a rash, but it's always, you've always got to be careful to not take that at face value. And so you often find yourself assuming a patient is allergic to penicillin when maybe they're not, but you're just not going to bother to test or check it. So I think
yeah. Sorry, in dentistry, we generally have to take the patient's word for it. We don't have access to the testing in quite the same way.
Yeah, and we would be the same as well. You've got to make a pragmatic decision. So I think the approach to antibiotics in patients with prosthetic infection is, I think, use your common sense. On the whole, the default position is no, but if there are reasons why you might have additional concerns, I don't think you can be criticized for doing that, particularly if there are reasons to believe that the patient's got active infection and or they're immunocompromised.
That's great. Thank you, Jonathan.
All right. Nice to talk. We'll talk again soon.
Bye.